Hello. Yeah. Good evening, everyone. Today we have another lecture in our toxicology lecture series. Today's topic is calcium channel blocker, beta blocker, and digoxin toxicity. This is a group that comes to our emergency department with a similar hemodynamical features and similar complaints, and yet it has a different way of management. So it's very important in our clinical management, yet it's very interesting topic or a favorite topic for examinations, including MD, DNB, or even MRCM examinations. So for the topic description, we have Dr. Achu. She has completed a DNB in emergency medicine and working as a consultant emergency physician in Medical Trust Hospital, Ernakulam. I'm very happy to welcome you, Dr. Achu, to the lecture, and over to you.
Okay, thank you, sir. Good evening, all. Myself, Achu Varghese. Today, we are dealing with the topic CCB, beta blocker, and digoxin toxicity. The mechanism and treatment of CCB and beta blocker are somewhat similar. So, any differences that we will discuss later. So, his story speaks. So, in every case, history is very important. So, 37-year-old patient brought to our ER by relatives in a comative state with a history of ingestion of 40 tablets of 5 mg of amlodipine. So on primary survey, area was patent, breathing, respiratory rate was 24, air entry bilaterally equal with a saturation of 100%. Circulation, pulse rate was 50, BP was 80 over 50, CFT more than 3 seconds. Disability was GCS was E4, V5, M6 per, GRBS was 400 with exposure temperature normal 98.6. So patient history of ingestion of 40 tablets of amlodipine, and patient had hypotension, bradycardia, and hyperglycemia. These are the most clinical symptoms of CCB poisoning. So coming to calcium channel blocker. The calcium channel blocker are two types, dihydropyridine and non-dihydropyridine. Dihydropyridine has more sensitivity to the peripheral vascular smooth muscle, and non-dihydropyridine has sensitivity to the cardiac myocyte. The examples of dihydropyridine is amlodipine, nicardipine, nimodipine, and non-dihydropyridines are verapamil, diltiazem. So how calcium works in our cell? So in smooth muscle cells, when a depolarization occurs, the sodium enters cells. So it will increase the current and it open the L-type voltage gated calcium channels. So there will be influx of calcium from extracellular to intracellular. This calcium bind to the ryanodine receptors in the sarcoplasmic reticulum. So sarcoplasmic reticulum already stores some calcium. So this calcium binds to the ryanodine receptors and stimulate the release of calcium stored in the sarcoplasmic reticulum. So there will be calcium releases from the sarcoplasmic reticulum also. This calcium bind to the calmodulin. This calcium calmodulin complex bind to the myosin light chain kinase, which phosphorylase and activate myosin, which causes actin-myosin interaction and contraction. So in vascular and smooth muscle, if calcium enters the cell, it binds to the ryanodine receptors, releases the calcium from the sarcoplasmic reticulum, activates the myosin light chain kinase, and activate myosin actin interaction and causes muscle contraction. So what happens in cardiac muscle? Cardiac muscle also, when depolarization occurs, will open L-type voltage gated calcium channels. So calcium enters from extracellularly to intracellularly, bind to the ryanodine receptors of the sarcoplasmic reticulum. They releases the calcium, which causes muscle contraction. So what will happen to the SA node? SA node is somewhat different. SA node, the membrane potential was around minus 60 milliwatt. At this membrane potential, HNC will open. This will and the sodium will enter through the HNC channels. So the minus 60 become minus 50. At this point, transient calcium channels will open and more calcium will enter. And it will become minus 40. This minus 40 is the threshold for action potential. At this point, the L-type calcium channel will open and more calcium will enter into the cell, which create an action potential. So calcium is needed for muscle contraction and generation of action potential. So in pancreas, calcium influx releases the insulin from pancreas. So what will happen when this all the calcium channel were blocked? So what will happen when calcium channel blocking? So there will be cardiac toxicity. There will be negative ionotropy that impairs the contraction, negative chronotropy, and negative dromotropy. And there will be also cause vascular dilatation, hypotension, decreased afterload, and coronary vasodilatation. So metabolic effect will be there will be inhibit insulin release and there will be insulin resistance. So manifestation will be serious. There will be hypotension, sinus body, AV block, AV dissociation, junctional rhythm asystole. Pulmonary, there will be a respiratory depression, apnea, GIT, nausea, vomiting. Neurology is metabolic. There will be hyperglycemia and metabolic acidosis. In ECG, there will be sinus bradycardia, varying degree of AV block. ABG, there will be metabolic acidosis. In blood sugar, there will be hyperglycemia because the insulin release is affected. In chest X-ray, there will be pulmonary edema. Echo, there will be impaired cardiac contractility. So, what will the management of calcium channel blocker toxicity? First is GA decontamination, orogastric lavage, activated charcoal, 1 gram per kg if the patient presented within 1 hour. Because of there is two formulation, immediate release and sustained release. So, patient taken sustained release, multi-dose activated charcoal, that's 0.5 gram per kg every 4 to 6 hours for sustained release, and whole bowl irrigation with 1 to 2 liter orally via NG tube or oral fluid. So our patient presented with the hypotension, bradycardia, and hyperglycemia. So in hypotension and bradycardia, we can initially give IV 10 to 20 ml per kg. For symptomatic bradycardia, we can and in calcium salt. So by administering calcium salt, there will be exogenous calcium. The exogenous calcium will increase the extracellular transcellular calcium gradient. So that it can give IV in 20 ml of calcium chloride or thrice the can be given repeat dose every 10 minutes, followed by repeated dose every 20 to 60 minutes. And we have to monitor calcium every 30 to 60 minutes. So high dose insulin. So we know that in calcium channel blocker, there is a decrease in the release of insulin. So in normal state, that our cardiac muscle depend on the fatty acids for the metabolism. But in stress state, that is in CCB poisoning, they majority depend upon the carbohydrate for metabolism. But in CCB poisoning, there is a decreased insulin release. So extra insulin, that is insulin increases in the CCB poisoning, the myocardium become more carbohydrate dependent because that is the myocardium is in a stress state. So insulin increases the intracellular transport of glucose into the cardiac muscle and also impairs the sodium, calcium, and the water, resulting in intracellular calcium. So it's a protocol for high dose insulin euglycemic therapy. Check serum glucose and if less than 200 mg per deciliter, administer 50 ml of 50% dextrose. Administer regular insulin at 1 units per kg IV bolus. Here we are administering high dose of insulin, 1 units per kg followed by 1 units per kg per infusion. We can titrate up to 10 units per kg per hour. So our set is to improve the heart rate more than 50 and to improve the systolic BP more than 90. So you have to monitor serum glucose every 15 to 20 minutes and titrate dextrose infusion, maintain a serum glucose between 100 to 200. And you have to also monitor potassium, maintain potassium between 2.8 to 3.2. So the next one is adrenergic agents. The patient who does not respond to calcium administration, who require multiple doses of adrenergic agonist, we can use norepinephrine, epinephrine to maintain a MAP of 65 mmHg. So the next one is glucagon. How glucagon acts is the glucagon activate adenylate cyclase. Adenylate cyclase activate ATP to cyclic AMP. This cyclic AMP activated protein kinase. The protein kinase enzymes, the phosphorylate the alpha subunit of calcium channel. So more calcium channel will be open, more L-type calcium channel will be open. So calcium enters from extracellularly to intracellular intracellularly and increase the calcium concentration. So we can give glucagon. Beta adrenergic agonist also acts in the similar mechanism. So a beta agonist activate the G protein coupled receptor. They activate adenylate cyclase. They convert ATP into cyclic AMP. They activate protein kinase. They phosphorylate the calcium channel, and more calcium will enter. So here high dose of glucagon have to be given. A bolus of 5 mg in adult and 0.03 mg in children given over 1 to 2 minutes. If no response in 50 minutes, this bolus dose can be repeated. If there is a hemodynamic improvement, a maintenance infusion rate of 5 mg per kg per hour in adult or 0.05 mg per kg per hour in children can be used. The next one is lipid emulsion therapy. So lipid emulsion therapy acts as a pharmacological sink for fat soluble drugs. So it absorbs all the fat soluble drugs. So it also provides a fatty acid substrate for cardiac energy supply, and it improves the myocyte function by increasing the intracellular calcium concentration. The dose is 20% lipid emulsion at a 1.25 ml per kg bolus or 2 to 3 minutes followed by 0.25 ml per kg per minute infusion. If the BP remains low, we can give an additional bolus dose of 1.5 ml per kg followed by we can increase the infusion rate to 0.5 ml per kg. We have to give a maximum of 10 ml per kg. The adjunctive pharmacological treatment is methylene blue. It inhibits the sodium nitric oxide mediated vasoplegia and the liver cement can be tried. The adjuvant hemodynamic support is transthoracic or transvenous cardiac pacing, intra-aortic balloon pump, ECMO or mask. So this is a case study which shows refractory shock from amlodipine overdose overcome by hyperinsulinemia. So in calcium channel blocker toxicity, there is hypoinsulinemia. That is, there is a insulin release is inhibited. So extra insulin can be given. So this insulin improves the carbohydrate uptake and it will act as a substrate in stress stage. A refractory shock from amlodipine overdose overcome with hyperinsulinemia. Then serum glucose concentration correlates directly with the severity of calcium channel blocker intoxication. So treatment of beta blocker toxicity also similar with the calcium channel blocker toxicity. Some specific features are different from calcium channel blocker is some agents that is like a propranolol are more lipophilic agents. They are more likely to enter the brain and cause delirium or seizure. Then some agents like betaxolol, carvedilol, pindalol, propranolol, they have sodium channel blockage activity. So sodium channel blockage may cause wide QRS and monomorphic ET. The ECG may reveal a Brugada pen. So what will be the treatment? So wide QRS widening and monomorphic VT. So we can give soda bicarb. Then next one is class 3 antiarrhythmic agents like sotalol. This has a potassium channel blockage action. So what will happen? It will prolong the QTC and causes torsades. So then we can give magnesium. Then betaxolol, carvedilol, labetalol, nebivolol, they have peripheral vasodilator action. So it may cause hypotension due to peripheral vasodilatation. That's all about CCB and beta blocker. So in CCB and beta blocker, there will be hypotension, there will be bradycardia and hyperglycemia in CCB, and in some beta blocker it is hypoglycemia. So our treatment will be atropine, IV fluids, high therapy, high dose insulin euglycemic therapy, calcium in the IV calcium gluconate, then glucagon. Glucagon is the treatment of choice in beta blocker toxicity, then intralipid emulsion. That's all about CCB and beta blocker. Then this is a case report about a 25-year-old lady died because of unintentional ingestion of a leaf juice. Actually, during the postmortem report, it came to be cardiac glycosid. It's arily flower. So next we are dealing with the topic digoxin. Digoxin is the cardiac glycosid we use therapeutically. Because of its narrow therapeutic index, its usage is limited to patient with heart failure with a reduced ejection fraction with the AF with a fast ventricular rate. So there are so many cardiac glycosides are found in natural sources. The foxglove, digitalis lanata, Iliophali, cane toad, oleander and all. So what is the mechanism of action of digoxin? So during depolarization, the sodium enters the cell. So which causes the opening of voltage-gated L-type calcium channel. So calcium enter from extracellularly to intracellularly into intracellular, then bind to the ryanodine receptors in the sarcoplasmic reticulum. It will release more calcium, then bind with the actin and myosin, cause cellular contraction. During relaxation, the sodium must go out to the extracellularly. Those there is a sodium potassium pump, which transfer 3 sodium outside and 2 potassium inside. So digoxin block the sodium potassium pump. So there will be increased intracellular sodium. So this increased intracellular sodium activate the sodium calcium antiporter. The sodium calcium antiporter works is 3 sodium outside and 2 they transport 3 sodium outside in exchange of 1 calcium. So there will be more calcium inside the cell. There will be increased intracellular calcium. This calcium will be stored in the sarcoplasmic reticulum. When next action potential comes, there will be large release of the calcium. And because of the increased intracellular calcium, there will be the resting membrane potential become more positive. So there will be increase the automaticity of the cardiac membrane. So there will cause arrhythmias. So in digoxin poisoning, we can see almost all arrhythmias except paroxysmal AF with a fast ventricular rate. So it has some autonomic effect also. There will be depolarization of baroreceptors in the aortic arch and carotid sinus. So they interpret as a vasomotor central hypertension. They activated solitary tract nucleus, and there will be increased the parasympathetic tone and via the vagus nerve, which causes bradycardia. So most cases of digoxin intoxication are chronic and unintentional due to the gradual accumulation of digoxin over time. There will be some precipitating factors. So digoxin is renally cleared. So any kidney injury may cause accumulation. There will be some drug interaction which reduces the digoxin metabolism. Other tissue sensitivity to digoxin may be increased with hypokalemia, hypomagnesemia, hypercalcemia, MI hypoxemia, hypothyroidism and all. Then fourth one is digoxin may interact with the other AV nodal blockers to promote synergistic bradycardia. So this toxicity can be divided into cardiac manifestation and extracardiac manifestation. The cardiac manifestation, any arrhythmia can occur in digoxin toxicity except paroxysmal AF with a fast ventricular rate. So the most classic was atrial tachycardia with AV block. The essential pathognomic was bidirectional ventricular tachycardia. The extracardiac manifestation will be nausea, vomiting, abdominal pain, fatigue, weakness, confusion, visual disturbance like xanthopsia, the yellowish discoloration. So it's a digoxin effect on ECG. This effect is not a marker of digoxin toxicity. It indicates that patient is taking digoxin. So there will be a scooped out ST segment. It's known as Salvador Dali mustache, reverse hockey stick sign and all. So paroxysmal atrial tachycardia with AV block. It is a classic tachyarrhythmia seen with the digoxin toxicity. So there will be increased automaticity with the AV nodal blockage. Then next one is bidirectional ventricular tachycardia. You can see the direction of QRS complexes. This is xanthopsia. So the therapeutic level of digoxin is 0.5 to 2 nanogram per ml is broadly regarded as therapeutic range. 0.5 to 1 nanogram per ml might be ideal for the treatment of refractory heart failure with a reduced ejection fraction. So after an acute intoxication, you should check the baseline digoxin level as soon as possible and repeat another level after 6 hours of ingestion. So digoxin has a large volume of distribution. So it requires almost 6 hours to distribute into the tissue following a oral intake. So this post-distribution level more accurately reflects the severity of intoxication and helps calculate the dose of digoxin-specific antibody fragments. For chronic intoxication, a single digoxin level is adequate. It is obtained more than 6 hours after the last dose. The treatment of digoxin toxicity in ER is always A, B, C, D. So airway, breathing, circulation. In decontamination, activated charcoal may be given if patient presented roughly an hour of an acute digoxin injection. Then digoxin specific antibody fragment. It is indicated for life-threatening or potentially life-threatening cardiac glycoside toxicity. So patient had a cardiac glycoside exposure with any arrhythmias, progressive bradyarrhythmia with the symptomatic sinus brady, second degree or third degree brady, or severe ventricular dysarrhythmia, ventricular tachycardia, ventricular fibrillation, or a potassium more than 5 milliclins attributed to CAS toxicity, or any other signs of acute or chronic CAS toxicity, or acute ingestion of more than 10 mg in adult or more than 4 mg in child. So one vial of digoxin specific antibody fragment neutralizes 0.5 mg of digoxin. So number of vials needed for the digoxin toxic management can be calculated by 3 formulas. So if a patient had consumed 50 digoxin tablets, so one digoxin tablet it contains 0.25 mg of digoxin. One tablet contains 0.25 mg of digoxin. So 50 tablets contain around 12.5 mg of ingested dose. So in digoxin, the bioavailability is around 80%. So 12.5 into 80% of bioavailability. That is 12.5 into 0.80. That comes one vial neutralized 0.5 mg. For 10 mg, we need 20 vials. That's 10 mg by 0.5 mg per vial. So it's based on the amount of digoxin ingestion. The next one is based on the serum digoxin concentration. It's little confusing. The number of vials equal to total body load. The total body load can be calculated by serum digoxin concentration into volume of distribution into patient weight. By 1000 is, here the serum digoxin concentration is in mg per ml. So the conversion rate is 1000. So serum digoxin concentration into volume of distribution into patient weight by 1000 into 0.5 mg per vial. As a quick estimation, we can calculate serum digoxin concentration into patient weight by 100. So number of vials, serum digoxin concentration into patient weight by 100. Another one is an empiric dosing recommendation. For acute injection, it's adult and child is 10 to 20 vials. For chronic injection, adult it is 3 to 6 vials and child it is 1 to 2 vials. So other hemodynamic stabilization, bradycardia, atropine is a good temperature measure since patient with a digoxin toxicity have excess vagal tone. So we can give 1 mg up to 3 mg. Then tachycardia, the best treatment is generally digoxin-specific antibody fragment. Avoid cardioversion if possible for supraventricular tachycardia. It may lead to ventricular tachycardia. For VT, lidocaine may be the first line agent. Magnesium sulfate can be useful. Amiodarone or procainamide that what has a poor AV node conduction can be avoided. If hypomagnesemia is present, this should be corrected. Hypocalcemia, hypokalemia, hypercalcemia, hypomagnesemia can exacerbate the effect of digoxin toxicity. Alternatively, hyperkalemia itself may be dangerous and requires treatment. For hyperkalemic treatment, we can give IV insulin dextrose injection, soda bicarb, or we can give potassium binding resins. Calcium should be avoided because there will be increased intracellular calcium load. So there is a risk for diastolic failure. It's called stone heart. Thank you. Any doubts?
Hope there are no doubts. It was a great lecture. We started with a clinical scenario. We went to the clinical evaluation and management of beta blockers and calcium channel blockers. And then we had a case scenario, real case scenario of having early flowers and getting cardiac glycoside toxicity. And we moved to the management of cardiac glycosides also. It was a great lecture. Thank you, Dr. Achu, for delivering this lecture. And thank you all for having here. We'll be back with another lecture. Thank you and have a good night.